say thank you to Dr. Lee for inviting me here, really. Although I have to say, when I received the invitation, I did hesitate because I couldn't think of anything that I can say that would deserve your time and attention on a Friday evening. But then, of course, I changed my mind 5 seconds later when I realized that the invitation was coming from the president of the Alumni Association, who that president is, and dire consequences that could befall me if I say no to that invitation. So here I am. This is a very happy day to give this talk because this is day 1 of your president assuming the position of the chief executive of the hospital authority. So it is also the first day of the 4th year of our Dean Lau's term of office. So he's very excited about it because he survived 3 years. He's not here, but let's congratulate him also for that. I have nothing, to celebrate myself with, except that I have recently also become, I've got a new title, which is I've become the owner of 2 new professors of our faculty. So this is just to update you that we have this new career trajectory path for dogs, for pets. So lately, Professor Lau, he appointed 6 dogs which belong to our staff as professors, and my 2 dogs, Uni and Kaki, were given these 2 lovely gold medals as their sort of gift for them. So I'm very grateful for Professor Lau. So today, what am I going to do to suspend your sense of hunger for 30 minutes? So I'm going to present some random thoughts that I have about our healthcare system. Nothing new, I assure you, but hopefully the perspectives will deserve your time. So first of all, per my title, who is this? Virchow? Logically, no, obviously it's not. He is one of the 2 Michelin brothers, which you'll find out, he looked a bit like Virchow. As you know, they owned a Thai company, the Michelin Thai company, and they published the first Michelin guide in 1990, which has now become the Bible of gastronomy with its 1 2-star, 2-star, 3-star system. Now, can anyone tell me the definition of a 1-star restaurant? And a 2-star and a 3-star one? Come on. No? Interestingly, that's how they define it. 1 star is worth a stop. 2nd is worth a detour. So, for example, if Dai Bei Bayview has got 2 stars, that means you're driving along Pokfulam Road, it's worth turning left. You go down Sassoon Road to have it. 3-star means it's worth a special journey. So if you're a Chinese university student, you drive all the way from Sha Tin to our Bayview to have a 3-star meal, which of course won't happen. Why do you think it's a funny way to describe restaurant using driving? But I'll tell you why later. Can anyone tell me, in 2025, which city has the highest number of Michelin star restaurants in the world? Paris? Who would say Paris? Who would say London? New York? You're wrong. No, it's not. It's Tokyo. One reason is because of the large population, but Paris number 2, and then London, New York, way down after 2 other cities. Hong Kong is not doing too bad. Number 7, 6 and 6, should be very proud. However, getting a Michelin star, even being mentioned by the Michelin star guide, is not always a good thing, as you can see about this restaurant that got mentioned in 2016, and then the rent went up for obvious reasons. It became a victim of its own success because the owner had to sell 11,000 bowls of dessert at the old price in order to stay open. Isn't fun. In a way, that's not very different from what our health system is suffering from. We were mentioned as the 2nd most efficient health system in the world. And look at what happened. We are still doing things at a very low price. our total healthcare expenditure per capita is increasing, which Dr. Lee can confirm. And when the government wants to reform it, people respond with something like this. They complain that the government just try to grab money. Just like if you increase the price of the dessert in that restaurant, your customers will complain. So our health system is also becoming a victim of its own success. Now, it's always tricky to talk about money and health together, especially when the government does it. The government has recently been trying to discourage smoking, which is something that the Czech Republic government had tried to do in 2001, and they conducted a cost-effective analysis, commissioned the Philip Morris company. They try to compare the pros and cons of smoking. Obviously, the cost of smoking is healthcare costs. But then at the same time, there are benefits of smoking. For example, from selling cigarettes, healthcare savings from people dying earlier, and saving from pensions and housing because people died before they can claim the pension and housing. So the net calculation is that if all citizens smoke, the government will gain 147 million US dollars. Now, if that is true, then there's no reason for our government to discourage smoking. And I know our government is not that bad, because if you listen, find out what the Czech Prime Minister said, he actually jokingly said, by smoking, he will contribute to the stability of the state budget. By buying cigarettes, I would increase state revenue, and if I die early, the state won't have to pay me a pension. That would be how a heartless, cold-blooded, cost-effective analysis would advise you. Obviously, our government is much wiser than that. How is that relevant? Come back to that later. For the time being, back to Michelin. Do you know Hong Kong, not only that it's the 7th on the rank of number of Michelin star restaurants, it's also the number 3 in the most expensive tasting menu around the world. Only topped by Macau and Copenhagen. Now Macau, we know why. Copenhagen, I have no idea. Which is fine, I think. Rich people eat better. The problem is not many people can afford a Michelin star restaurant. In Hong Kong, more and more people are eating this, Leung Song Fan, 2-dish rice. Very tasty, but then, if you believe this article's point of view, isn't the popularity of 2-dish rice actually a sign of worsening widespread poverty in Hong Kong? And it is more worrying when the Hong Kong Sanatorium, the Michelin star of our hospitals system, is also introducing 2-dish rice. Now, something is wrong when people are eating Leung Song Fan in the Hong Kong Sanatorium. Now, how does it matter? What does it mean to our healthcare system? Here enters the real Virchow. Any medical student here? Any? Suppose someone to be presenting? No? Well, the graduated one, you know who Virchow is. Now, he is the one who described the node, the triad. But interestingly, how many of you think that Virchow node is always on the left? Apparently it's not. Depending on your venous lymphatic drainage and the stage of cancer, Virchow node can actually be left or right. So the Torsay sign that we describe all the time, use all the time, should actually be specified as left or right. That's apparently what the author is trying to say. And Virchow had described that, and it became known as the father of modern pathology. He described the cellular origin of disease. And he's also a very interesting gentleman in the sense that he was an anthropologist by habit, I think, by hobby. He was very much opposed to racism. He opposed the idea of an Aryan race. He published widely, but when his paper were being rejected by many journals, he started his own journal, which is now the European Journal of Pathology. It's a very handy thing to do. What is relevant is that he's also politically very active. When he was young, he went to a typhus epidemic in Upper Silesia, which is sort of, you can see where it is, near Czechoslovakia. And he was studying the famine fever at that time, it's called. And his major discovery was that the epidemic's root cause was not individual illness or bacteria, but poverty, lack of sanitation, and poor living condition. And he was, therefore, the founder of social medicine. He was the first one to describe not only the Virchow's notes, but the idea of there being social determinants of health. And that has been proven true till now. That in the US, as you know, poverty by itself is the fourth most important cause of death. By itself. The public health people will tell you how independent that is as a factor of cause of death. And in Hong Kong, we have that. You know that. Now, we'll wonder, some of you, especially the junior ones, how does it matter? We have our universal healthcare system. We have our HA, the safety net. The problem is our dual system is premised on the assumption that the free market invisible hand, the supply-demand cost adjustment would work so that the rich people will go to the private system, the poor people will stay with the public system. But that is obviously not the case. When we talk about a free market, we're talking about something on the left-hand side. You go to a supermarket, you want some noodles, you want, some juice, Coca-Cola. You know what you want. You know how much you can afford. You know the price of everything. When you go to the counter, you pay, you go. Everyone is happy. But when you go to a private system, number one, you don't really want to go in the first place. Number two, you hardly know what you need. And you don't know how much they cost. You don't know how to choose from them. And once you're in there, things get added to your baskets without you knowing, without you consenting, without knowing the price. And you went in with the estimate of 100,000, you leave with a bill of 300,000. That is not a free market phenomenon. The result is due to mainly unnecessary treatment. This is a book published last year by a Hopkins surgeon. He estimated that 30% of healthcare in the US is unnecessary. It is wasting $1 trillion per year. There are many, many reasons. Doing more, you earn more, is obviously the main incentive in the fee-for-service system. And there are others, pretty obvious reasons. In Hong Kong, that results in something like this. The medical insurance company is screaming because the premium rose by 7.5%, whereas the underwriting loss increased by 144%. So the medical insurance is a loss-making business. And they would be left with two options. Number one is to increase the premium, or it cuts down protection. Neither would be ideal. And you might end up with a situation when your insurance company will tell you how well you are and how well you are not. So ideally, in the healthcare system, a truly free market healthcare system, you need something like this. You know exactly what you need, and when you add something, you know exactly how much they cost. That is the ideal system. And hence, our secretary asking for price transparency. I love this slide because it's not often that you can put CMO next to a Foodpanda screen capture. But I propose that even price transparency by itself would not be sufficient. Because how many of you like pineapple on pizza? Yeah, pineapple on pizza is good. Well, if you know it, how much it costs, you like it, you add it, that's fine. The question is, how do you know whether you actually want or need pineapple on pizza? Because if you ask the Italians, they would say, I'd rather die than having pineapple on pizza. For the younger people, that is Marlon Brando in Godfather. So price transparency itself is not sufficient. What you need is to tell people when you need pineapple, when you need chicken tikka on your pizza. And here comes the Italians. The IMAs, established by the government, we were inaugurated 8th of May, is an independent platform funded by the government. The Secretariat sits in the Academy of Medicine. I have the honor of being the convener. And then there are 7 founding members: Department of Health, the 2 deans, Academy of Medicine president, Private Hospital Association president, Primary Care Commission, Hospital Authority executive. I will quickly change this picture tonight. This PowerPoint was done before 1st of August. So the primary object of this IMAs really is to establish clinical guidelines so that people know what is necessary treatment, what is not necessary treatment, what is cost effective, what is not cost effective, and it would also do public education. So I think this is a very positive way to keep patients informed so that they can make the right choices and ask the right question when they see a doctor regarding treatment. And together with price transparency, hopefully the costing on the private sector will self-regulate a little bit better. And hopefully will balance out things between the 2 sides. But however, there are other challenges involved. This is a picture taken from Park Hospital in Manchester, 1948. Sylvia Diggory, she was the first NHS patient. What captures my attention about this picture is her look. She was very healthy, wasn't very sick, and yet she came to hospital for care. And she has this look of total trust, if not submission, to the doctor. And that is the kind of relationship that we have been used to for the last 100 years almost in Hong Kong, the doctor-patient relationship. But all these things had changed in 2008, in a December, rainy evening in December in Paris, December 2008, when these 2 gentlemen, future founders of Uber, failed to get a taxi cab. And then Travis said to Garrett and say, what if we can actually order our cab by tapping on our phone? That's the beginning of the idea of Uber. And of course, Uber was founded in San Francisco in 2009, and there it is, the Uber world. What it means in medicine is this. Now we have Uber Dog. By the way, it's not owned by Uber. It's something that stole the name of Uber. They had a lawsuit. You can find your own doctor. In Hong Kong, we already have an online web platform when you can get your doctor, choose your doctor, and have treatment and diagnosis online. And you don't even have to see them because low-level industry will bring medications to you. And even if you have to go to a hospital, you can get Uber Health, which will time the taxi so that you won't have to wait outside your OPD doctor's consultation room. That is owned by Uber, by the way. So the way that patients seek help, the way they prefer the interaction with doctors have already changed and will continue to change. And the Uberized world has also changed the way professionals work. You know, in the old days when in a place like Queen Mary, the Michelin Hospital in Hong Kong, when professor shouted at you, you tremble, you listen, you bow, and you obey, right? Dr. Leung, that's how senior interacted with juniors. But now when you ask a junior to go away, he will say, you go away, right? And they want different work-life balance. So Uber provides a perfect platform for them to do gig work. They don't really want to be employed full-time. They don't want to work Monday, Friday. They work Monday, Friday, sometimes Tuesday, Wednesday. Nurses are doing that already. And then very soon, I think many young doctors will be doing the same too. The impact on our manpower situation, our ability to project manpower need will be very, very different. However, it's not always bad. Old people, retired people, you can do gig work too. This is from Taiwan. There are many retired doctors already doing gig work, visiting old people or people younger than them. So it's another career opportunity for us too. So what we are talking about here is the Uberization of medicine, which means service is on demand, initiated by patients, has to be digitally accessible, immediate, convenient. Importantly, there must be plenty of choices. They won't be happy if I walk into a hospital and I can only see Dr. X. They want to know I have Dr. X, Y, Z, A, B, D I can choose from. They want the cost clear, transparent, and that fits the budget. And we have freelance providers. Now, this is not always a bad thing. Under that system, access and efficiency will be improved. Cost would probably be reduced. Waiting time will be shortened. There'll be better data integration because the healthcare data will be within the same system. They know more. They can find out more about the doctors. They can find out the surgery before they see you for consent, and they're more in control and they get what they want or what they think they need. So, which is everything that medical ethics tell us that we should do. So it's not necessarily a bad thing. What is worrying, though, is that it would transform that kind of silvery degree doctor-patient relationship to a consumer-provider relationship. Now, that we can go on for a whole day about whether it's his right to call patients consumers, but like it or not, I think that kind of trend will happen. I'm not going to debate on that. I'm going to look into whether we are ready to regulate and cope with that kind of new landscape, Uberization and patients becoming customers. One example is if you look at the Medical Council's Code of Conduct, it still has this signboard where how big it is, how tall it is. It talks about your stationery. Is Professor Grace Tang online or something? She's not, is she? No, good. No, so that it's just completely irrelevant to me because people go online. They find out much more about you quickly, immediately. So what is this code doing? Talking about fit for purpose. Is this code really fit for purpose? I don't think so. And even when the Medical Council has convicted someone for misconduct, how do people find out? You can't. They publish the judgment chronologically. So if you want to know whether, if I see this particular doctor, whether he has been convicted, you have to go through all judgments, which is impractical. Whereas I did it the other day, I'll find, ask DeepSeek, which neurosurgeon in Hong Kong has been convicted. They gave me a name, the reason, the source of information. Now, this is the world that our patients will be living in. This will dictate their health-seeking behavior. Now, I'm not saying that we should allow doctors to advertise like what they do in the States, going around telling people I'm the best. But there must be a better way. There should be a better way that we can keep our patients well informed. Perhaps an official website run by the government, detailing expertise, even charges, even what they are good at. So it's kind of a controlled promotion. Even their conviction, maybe something by the government. No one would like it, but at least it's better than patients going randomly on different platforms and websites and getting possibly wrong information. Hong Kong can do it because it's small. China, you can't. It's too big. Just saying. All right. So this is something I think we can consider. But to me, the most worrying thing about this Uberized world of healthcare is that inevitably you retain, if not promote, the idea of consumerism in healthcare. And therefore, doctors, industry would have to face this problem, how they serve two masters. Now, talking about Ubers and cars, one of the most well-known business ethics case concerning safety and cost is the Ford Pinto case. Has anyone seen one? The more senior people would have seen one. It's in your era, right, Dr. Leung? You've driven one. Okay, well, lucky you, because the Ford Pinto was a very popular car. Apparently, it's very dangerous because it has, initially, the gas tank was down here. So when it got hit from the rear, it exploded. Many people died. Ford could have modified it and put it deeper and higher up so that it reduced the risk of explosion. And then they calculate the cost. If you modify the fuel system, you would save lives, serious injury, vehicle repair. There would be roughly about $50 million benefit to society. The cost of changing is very low. It's about $11, but then there are too many of them. So the end result is that you would spend $137 million changing it. Now, which company would change it? None, of course. So when it's not customer safety, when it's patient safety, how would the decision-making process go? I'll leave it to you. And things become obviously far more urgent in an acute situation such as this. I was doing this PowerPoint and then there was a typhoon. And then someone complained that taxi raised its charges by 150, which is not much in under number 10. But then someone got very upset about it. Under emergency situations, this kind of haves and have not situation can be exacerbated. Earlier this year, we had this fire in California. And there were house owners who actually employed private firefighters. They paid it up front. And these firefighters would obviously put out fires over their clients' land, but not next door. Now, how many of you think there's something not quite right about it? Let me ask you another way. If you are a poor family, you can't afford a private firefighter, and 5 of your neighbors all have private firefighters, which means if there's a fire, there'll be firefighters coming in. They'll put down a fire over their house, but not your house. Who do you think that? Do you feel good about it? Probably not. Probably not. But what if you can afford it? Who would pay for a private firefighter? You see, that's what I did too. I think it's wrong, but if I can afford it, would I do it? Yes. So what if the same for healthcare? What if the same for healthcare? There are things that the rich can afford, they can pay for. It's not wrong. But then everyone around him cannot afford it. So ladies and gentlemen, what I'm trying to say is next time when you examine a patient or when you teach a student examining the supraclavicular fossa, think about Virchow, the man who said this, that medicine is a social science and politics is nothing else but medicine on a larger scale. Meaning there are things that affect healthcare beyond simply the bedside, beyond surgery. Or you can look at the other way. Medicine is in fact just politics on a smaller scale, in a way that how different forces can actually interact and affect your patient's outcome. So I started with Michelin. I'll close with Michelin. I asked you why Michelin described restaurants using worth a journey, worth a detour, etc. Because the whole point of the Michelin brothers publishing the Michelin Guide was to encourage people to drive so that they need more tires, so they do better tire business. That is the story behind the Michelin Guide. And that's the story behind the definition of 1-star, 2-star, 3-star. But then you would never expect that about 45 years later, in World War II, after the Allied forces landed on Normandy, they were trying to move inland. But then they found out that the Nazi soldiers had burned down all the road signs, so they couldn't find a way until they realized they could rely on the Michelin Guide's map to find their way in occupied France. And allegedly, the Michelin Guide had helped the Allied force to liberate Europe. So what I'm trying to say is, you never know. Sometimes what seems business orientated, could be very useful, could be very good. It could also be a matter of perspective, because talking about the two-dish rice, you can say it's a sign of poverty. You can also see it as the way Hong Kong people cope. That it actually gives you hope, because even though you have a low salary, you have lost your job, you can still eat. It may be just a representation of our city's lion rock can-do attitude. So, ladies and gentlemen, with this, I would say whatever difficulties that we have here in this faculty, in this university in Hong Kong, as long as we hold on to this two-dish rice spirit, I'm sure we will weather all the storm and find a better tomorrow. And with that, I thank you for your time and attention. Thank you.